technical details. All the lines have come in muted, so there's no background noise to distract our presenter. And you should notice a question box in the right-hand side of your screen in the control panel. So as the presentation unfolds, feel free to write your questions or comments in as they occur to you. There will be a video shown during this presentation, and we'd like to encourage a really interactive session. So let me know if you'd like your line unmuted, if you have any comments you'd like to get into a live chat with our presenter or with any of the other participants. And like all of our presentations, this one's being recorded, and the recording and any other resources or documents provided to me by our presenter will be posted on the CAPHC Knowledge Exchange Network. And it usually takes a couple of days to get that information up, and you will receive an automated message from the system with a direct link to that page. Although you can use the search function of the CAN as well to find the information as well. So here we have the Knowledge Exchange Network, and it does provide space for comments, and we would encourage you to keep the conversation going. And if you have any other information that would be relevant or questions or comments, please feel free to become a registered user of our Knowledge Exchange Network and continue that conversation. So I'm now going to hand the virtual podium over to Darlene Bolivar, the chair of the CAPHC Patient Safety Collaborative.
Good morning, everyone. Thank you, Lisa. It's my pleasure to introduce our speaker for today. And for many of you who've been involved in CAPHC over the years, you may be familiar with Dr. Mark Fleming and his work. He is well known in the field and has done previous work with CAPHC organization. So Dr. Flemming is the CN Professor of Safety Culture. He received his Bachelor in Psychology and Master's in Human Factors from Aberdeen University in Scotland and his PhD in Psychology from the Robert Gordon University in Scotland. Mark is an applied psychologist with 20 years of experience in industrial health and safety management in high-hazard industries, including the offshore oil and gas, nuclear power, petrochemical, power generation, and construction. He is dedicated to developing practical and valid tools to assist organizations to prevent harm. Currently, Mark's research includes investigating methods for measuring and improving safety culture, safety motivation, safety leadership, and rail safety. He advises many Canadian and international organizations, such as the International Atomic Energy Agency, on safety culture assessments and improvement. Through his work, Mark has hopes to provide best practice guidelines to industry and criteria for successful safety programs. He seeks to translate his work on safety culture into usable practices and guidelines by producing practical tools such as the Changing Minds Guide and the Cultural Maturity Tool. And on a personal level, Mark has worked with me and my organization in the past on developing and helping us advance our safety culture here at the IWK as well. So it's my pleasure to introduce and turn the podium over to Mark.
Thanks, Darlene. Thank you, Mark. And great, okay. So hopefully this is going to work. Okay, so I'm hoping that everybody can hear me because everyone else has gone mute. So thank you, Darlene, for that introduction. So yeah, I'm going to spend the next little while talking about patient safety culture and specifically talking about finding the patient in patient safety culture. I know that webinars can be a little bit tricky in terms of our ability to sort of communicate and interact, and I'm going to stop a couple of times during the session to ask you a couple of questions, which you can hopefully type in the chat so we can interact a little bit to each other. And when you are typing the messages in the chat, I think you can select to everyone, and that would work pretty well from my perspective. So my objectives for this webinar today are to help you understand the nature and importance of culture and its relationship with patient safety. We'll talk a little bit about some of the current assessment strategies, and then, you know, going back to the title, we'll talk really about where there's a patient and family fit into this concept, and where we're going now in terms of improvement strategies and maybe some new ways of thinking about culture from a slightly different perspective. So really, you know, since the IOM report 99-2000, there was been a big focus on culture within healthcare, and you know that focus has brought a lot of attention onto patient safety culture. In Canada, Accreditation Canada, as part of their accreditation process, does a survey, and we'll talk a little bit about that later. And really, over the last sort of 10 or 15 years, there's been a lot of discussion about what patient safety culture looks like, how you go about developing one, and also there was a sort of sense that, you know, really it's essential that the culture within healthcare changes so that we can learn and improve. And particularly, we were talking a lot about moving away from blaming individuals for errors to focus more on learning from those particular failures. And we'll talk a little bit more about why we've taken the path we've taken, and maybe where we go from here in terms of what we've achieved or what we haven't achieved. Oops, I'm not up there. I'm going to go back up one. So I've got a picture up here, a cartoon, which actually John Carroll from MIT shared with me. And, you know, I think it's it's one of those sort of business ones, and the caption at the bottom says, I don't know how it started either. All I know is that it's part of our corporate culture. So I just want to sort of check that there's someone out there. So if you could type in the chat, what's the it when it says, I don't know how it started either? What is the it that they're referring to? Anyone got any ideas as to what they're talking about?
Somebody said the hats.
Okay. So the hats would be one of the potential things that we could have be talking about here. And you know that's the answer. But I suppose the question for me is, why the hats? Why are we picking the hats and not necessarily the desk, the pictures, the clothes that they're wearing? They're all wearing suits. And I can imagine in a few years' time, people would wonder what those funny boxes that looked a bit like old TV screens are doing sitting at their desk, because I don't think computers will look quite like that. Or what are those funny objects on their desk that look a bit like phones? So we say the hats because to us, all the other things are sort of typical within our day-to-day sort of culture and in an office setting, and the hats are somewhat unusual. Does that sort of make some sense?
Yeah. So Mark, sorry, Mark. So Lynn is saying, yeah, the hats seem the most useless to the job.
Exactly. Although I'm not sure the blotter sheet is that useful either. But there's a sort of sense in which when we look at this picture, it's what we expect to see in an office environment, and the hats seem somewhat different from what we would normally see, and they're different from what our cultural expectations are around what people wear when they're in an office setting. And I think what's interesting about this, and why you need to think about it from a cultural perspective, is that many things in our culture, if it seems normal to us, then we don't even notice it. So many of the cultural norms and expectations we have about how people are going to act, what people are going to wear, are taken for granted, and we wouldn't particularly take note. It's often when we notice something, it's either different from what we would be expecting. So one of the things that's good is to travel. I would encourage people to travel. It's a very useful activity. But one of the benefits of that is when you go to a different country or culture, you can notice things that you think, wow, that's a bit different. And that you learn both about the culture you're visiting, but also about the culture that you're from, because you start to notice the differences between those cultures. And I think that's really the point that I'm trying to make here, is that when we look at our culture, some of the things we don't even notice or see anymore because we take them for granted, they're assumed. So it can be a bit of a challenge to try and get us to step back and look at it from a different perspective. So hope that makes sense. So I think it's important for us to understand the definition of patient safety culture, and this one's from Kaiser, and I like it as a reasonably good description. So a culture of safety can be defined as an integrated pattern of individual and organizational behavior based upon shared beliefs and values that continuously seeks to minimize patient harm that may result from the processes of care delivery. So there's a couple of reasons why I picked this particular definition. One is, it's not to say that the culture is really about thinking that patient safety is important. I think everybody in healthcare thinks taking care of the patient is important and minimizing harm is important. The debate and the cultural issues are often around how we do that and the extent to which we need to change what we're currently doing. So often there's maybe a belief that harm doesn't occur, or that it occurs because of one or two bad actors. But the real culture that we're talking about is how do we promote continuous improvement and to look at how we can enhance safety using sort of systems and processes. And what are our beliefs about what the nature of patient safety is and how do we achieve that level of safety. So when we talk about the culture that we're looking for, it's not a culture that says, oh, taking care of the patient is really important, because I think that's pretty broadly true. What we're really talking about is a culture that focuses on how do we reduce the potential for harm that might happen as part of the care we deliver. And to focus on that, you have to first accept that harm can and does occur to people as part of the care delivery process, and sometimes that's often not accepted. So one of the things that I think can be helpful is to sort of think about culture and try to sort of think about what it looks like in practice. And I used to, a number of years ago, nearly 20 years ago now, work as a consultant in the UK, and I was we had this we were a small company. We had a marketing guy come and present, and he used, always break everything down into a sort of 2x2 matrix, whereby no matter what the problem was that you created, he always broke it down into a 2x2 matrix. And I was a bit younger and more mischievous, and as our meetings would approach, I would try to dream up ways in which I could come up with ideas or problems that wouldn't break down into a 2x2 matrix. And he would listen to me for a while, and then he would summarize what I was saying and always be able to break it down into a 2x2 matrix, which drove me crazy. But what I took away from that is if you understand something, you should be able to summarize it into a 2x2 matrix. So I try to do that a lot. So here's my attempt at the 2x2 matrix around sort of culture and behavior. So the two sort of the two issues are whether the culture is safe or unsafe. So is it sort of positive or negative culture? The next one, is it strong or weak? So a culture can vary in the extent of how strong it is, or whether it's very weak. So if it's very strong, then there's lots of consistency in behavior. If it's weak, then there's lots of variability, and cultures having less influence on people's behavior. So first of all, this sort of desired culture, and in this sort of square, you've got sort of behavior can either be red, which is unsafe, amber, which is sort of in between, and green, which is safe. So we're sort of simplifying things here. And in this case, in a strong, safe culture, you would find that people's behavior would be pretty consistent and would be located in the center of that sort of green box. And you can see these little smiley faces. That represents people. People's behavior is very consistent, and there's very little variability in people's behavior, and it's all pretty much located in the center of the green zone. And if someone came in and was behaving in an unsafe manner, then they would be very quickly told that what they were doing was unsafe and not acceptable. And if they persisted, then people would become relatively hostile to that individual, and their behavior would not be acceptable. And either they would end up behaving in the way that was appropriate, or they would end up leaving the organization. So in an organization with a strong safe culture, it's not acceptable to not behave in a safe way. People will not tolerate it, and there is, a pretty strong reaction, and people's behavior is pretty consistent in that sort of context. And in sort of healthcare, if we think about hand hygiene or hygiene, if we think about, say, the norms of behavior around hand washing in a surgical, in an operating theater, it's not tolerated for people to not perform that activity. If you go in there, people will shout at you pretty quickly if you're going to break the sterile environment. So there are some examples where the norms are particularly strong within healthcare organizations. Yet in other parts of hospitals, hand hygiene is not quite so rigorously enforced, leading to some negative consequences. So we can see there are some examples of strong safe behaviors. On the other hand, you can imagine in a safe but weak culture, in this case, people are safe just because the individuals there happen to be safe. You can sort of tell from this diagram it's not as safe as the strong safe culture, because you have people who are in the orange zone, and there's lots of variability. People do things their own way. They don't tell each other to behave in a safe or unsafe way. And if someone came in and was behaving in an unsafe manner, people wouldn't intervene. They wouldn't say anything. It was sort of everybody up to their own devices, and there's a lot of variability in people's behavior. So the culture is not in that situation influencing people's behavior. There's a lot more variability in that sort of context. And so it's pretty easy to imagine how you can go from a safe, weak culture to an unsafe, weak culture, whereby you have different people turn up, or there's a change in demands, and you very quickly move to a unsafe practice in that sort of context, because people change, or the focus changes, and people behave in an unsafe way. And then finally, you can have an unsafe and strong culture. And in this sort of context, you have people who are acting in an unsafe way know what they're doing is against the rules. They have decided for whatever reason that that's the way they're going to behave, and it's an accepted practice. So they know what they're doing is wrong from general norm or standard. They do decide that they're not going to follow that norm, and they are in unsafe practice. So that is a sort of unsafe practice. I don't know of any examples within healthcare where that occurs. I wouldn't be surprised if it does happen, where you sort of get these sorts of very strong unsafe or practices. At least in Nova Scotia, if you drive around the south end of Halifax and look at residential roofers, then you will see in that context that often people are on a roof and not wearing a safety harness, or they're wearing it but they're not connected to anything. And that's a pretty strong norm in that business. And if you turned up out of community college, having had all your safety training with your safety harness, and asked the person, where do I hook this on, they would probably find it amusing for the first little while, but ultimately you'd have to get with the program and follow the safety rules, follow the practices of that group, which is to not wear it because it slows you down. So in those contexts, if you came in and followed the rules and tried to behave in a safe way, you would be treated poorly, eventually pushed out of the organization or the group, because that safe practices are not accepted for that group. So that's the sort of the broad sort of paradigm for just to sort of try to give you a sort of sense of what culture is like. I'm going to spend a few minutes just talking a little bit about the sort of assessment process, because a lot of organizations have been involved in assessment in one shape or form or another. So I'm going to talk a little bit about that. And this is, quite a busy diagram, but it's really, if you're going to use assessment and improvement as a package, you probably need to go through this process. And so first of all, at the start, you have to build some capacity. So organizations need to understand a little bit more about safety culture and about how you go about doing assessments. So there needs to be some capacity within the organization to understand the concept and understand what's involved in doing it. Part of that capacity is also going to be to educate leaders about the nature of safety culture and what's the purpose of the assessment and what are the potential outcomes. And I think when organizations go wrong in terms of doing safety culture assessments, one of the fundamental errors they make is that they don't do enough upfront work educating the leaders about safety culture and trying to get them on board to understand what they're doing, why they're doing it, and what this is going to look like. Because often when they find out at the end and when problems arise, it's often that there's been a fundamental misunderstanding about why we're doing it and what we're doing. Then once you've done that, you're going to have to select some assessment methodology, some survey instrument, educate the leaders about the process of doing the assessment, so get informed leadership support so that they know both what's involved, what their role is, and what the likely process and outcome is going to look like. Then once you've got their support, you need to involve a sort of a cross-section of healthcare staff in the process so that you know what's happening and they've had some input into it. You distribute the survey and collect some data. Then you can do some analysis of that data and interpretation. Then you feed back the results, both to the leadership team, but also to the participants who completed the survey, and collaboratively identify interventions. So what we typically advise is that you go back at a team-based level, feed back the results to each unit or team, and from that, get them to identify improvement strategies. So really often improvement strategies really happen at a very much a local level. And when you're feeding back the results, you're not making a value judgment saying, oh, well, you were team X and you were bad, you need to do a lot of improvement, and team Y, well, you're great, you need to do any change. It's more about, well, okay, here are the results we've got for this team, what's that telling us, and what can we do to improve? And that's often missed out. People focus a lot on wanting to, you know, color code their teams red, amber, and green, and say, oh well, here are the baddies, and you know we're going to give them get them into trouble and tell them they need to do something good, or here are the really good guys. Let's just say how great they are, and that really rarely does that help for improvement. The people who get colored red, resented, and just criticize the results. The guys who get colored green think, oh, we're great, we don't need to do anything. So my recommendation to organizations is don't color code, just present the results as they are, ask the people who you're presenting them back to interpret those results with you, and think about ways we can improve. What are we going to do differently? How can we make things better here? What does this tell us that helps us identify improvement strategies? And then you go and you implement some interventions based on that, and then you go and track the changes. So to what extent, A, did you implement what you said you were going to implement, and is it worked as intended? And then after a couple of years, you might go back and go through the whole process again to see if there's been any change or improvement. So that's making sense to people. How we're doing time-wise. Okay. So there are a wide range of assessment methods. In that assessment process, I really described it as a perceptual survey methodology, and really I've talked about that because that's what most healthcare organizations in Canada do, mainly driven by Accreditation Canada. From a culture assessment more broadly, if you go outside healthcare, perception surveys are still the most dominant form. They're often not the most helpful, but they're the ones that people seem to think they can do. So there's a lot of focus on that. There are other measures like interviews and focus groups, which again are perceptual, asking people what do they perceive around the culture. They tend to be, more labor intensive. They don't tend to produce numerical data, so people often are uncertain about the meaning. But they do produce a rich picture of the culture. And for the work I've been doing, say, particularly in the last 5 years, my focus has been in this domain. More recently, I've been starting to work on methodologies that include document analysis, observation, audit. So where we can go do some analysis of documents and see what that tells us about the culture. What can we see if the culture, if culture is important, we should see it in terms of outcomes that are documented in one shape or form or another. Another methodology is to do observation, just to have an observer watch people, and yeah, observation, people will change their behavior, but if the person stays there long enough, people go back to their normal routine. Audit is this idea where you can go and look at some observations, some document analysis together, maybe even do some interviews and sort of pull that together into an overall view. Ethnography, not so common in patient safety culture, but could be done, and that's really where you sort of go and live in the culture for a period of time, record your observations, and draw some inferences. So it's a much deeper, longer term type of analysis that someone could do about their journey for improvement. So those are the broad methods. Perception surveys being the most dominant, have often now combined with other methods, including interviews, focus groups, and document analysis. So one of the things that is happening in the broader safety culture domain is there's really a move towards a much more sophisticated assessment process in other industries, which is maybe, to the best of my knowledge, healthcare hasn't taken on board just yet. So in general, what we now do outside healthcare is we will do perception surveys. We'll generally supplement that with focus groups with key players both before and after the survey results are obtained. We also try to triangulate the results with some analysis of documents like near-miss reports, incident analysis, and other safety system activities, and may also do some observation to capture some of the culture and practice. So the domain of assessment has moved forward in the last 10 years or so. So I just want to talk a little bit about the sort of main sort of domains or aspects of safety culture from the literature. So in 2003, Singer et al. Did a review, and this is sort of consistent with reviews subsequently and other reviews in the domain to identify the main elements of patient safety culture: leadership, commitment to safety, organizational resources, balancing the sort of priority for safety from a systems perspective versus delivering care to patients, so balancing production versus safety. Effectiveness and openness of communication, to what extent are we communicating effectively both up and down the organization and between teams. Openness about problems and errors, organizational learning, so those two things are sort of quite closely linked. So are we willing to report errors, and if we do report them, do we learn from events in the past, and sort of an outcome variable, sort of unsafe behavior, so how much sort of unsafe behavior is accepted within the domain. So broadly speaking, those are the things that are assessed by questionnaires to varying or lesser degrees. If we come to Canada, Leanne Ginsberg and her group developed the modified Stanford instrument, which initially had 5 domains: organizational leadership for safety, so that's senior management commitment to safety; unit leadership, which is mainly about supervisors' commitment to safety; perceived state of safety, well, where do you think safety is at within your organization; shame and learning, and that has been used widely by Accreditation Canada, and has some reasonable psychometric properties. More recently, Accreditation Canada has updated or changed the questionnaire that they're using. So they have modified that previous questionnaire and produced a new one, which is the sort of Canadian Patient Safety Culture Survey, which was revised and developed by Leanne Ginsberg. And again, some of the dimensions stay the same. So organizational leader support for safety stays there. Supervisor leadership stays there. Instant follow-up, which is sort of a bit like taking action. Unit learning for culture, so to what extent do we learn as a unit. And open communication, this is judgment-free, so people aren't critical if you report an error. And job repercussions, so you don't get disciplined if you report a near miss. So it's a modified version of that. Again, pretty large data set, reasonable psychometrics, and it's the one that's been used broadly in Canada now. So if you're going through accreditation either in the last year or if you're doing it in the next couple of years, this is the survey, if you choose that option, that you're going to be using, and these are dimensions that you're going to be assessing. And broadly speaking, it's similar to some of the elements that have been identified in the literature, and so it's pretty consistent what's been measured by most surveys out there just now. If we go back to the title of my talk, then we can ask the question, where's the patient in all of this? And I think that's one of the big gaps in the literature so far. So where is patient engagement in this process? You know, why don't we see that as an element? Where do we don't talk about healthcare providers' view of patient engagement. We don't have any dimensions about patient or family engagement in patient safety. And you know, I think that's a major gap in the survey literature and in the surveys that are currently being done in both North America and actually the rest of the world. So really, one of the things that the reasons for this is that the surveys that we started using in healthcare, you know, around the early 2000s, were based on research in other domains, whether it was the offshore oil and gas industry or aviation. That's the basis of the surveys that started. So those dimensions were the ones that people focused on when we talked about healthcare. And also, 15 years ago, there was less focus on patient engagement. It wasn't such a big issue. And a lot of the early focus in healthcare was on blame and reporting. So there has been some research looking at provider views of patient engagement, and Andrea Bishop, who now is a postdoc at Dalhousie University, has done some really interesting work looking at provider views of patient engagement. And actually, providers aren't as all singing in light when you start talking about patient engagement, and aren't necessarily that welcoming to patients criticizing them or being in any way negative about their work or challenging them in terms of the practices. And I think that's an issue that, you know, we haven't really directly addressed in healthcare, particularly not from a patient safety culture perspective. So I think there's a gap in the surveys that we're currently using, and it's in that sort of domain. As part of her PhD thesis, Andrea developed a survey to get into attitudes to patient involvement. She talked about asking about the factual exchange of information, you know, encouraging patients to challenge providers. So there was a number of items which patients were asked to identify themselves before giving a new treatment. You know, are they willing to challenge providers, and how would you respond? Would you be willing to really listen to a patient? Do you think they have worthwhile information? And workload, you know, so the patient's question, you know, increase my workload. So to the extent to which how providers view patient engagement, I think, is an additional element that should be added to patient safety surveys. Right, I'm going to do this. Okay. So, where are we? So I want to just stop there. I want to be able to do an exercise with you. So all of the stuff that I've talked to you so far about has been about pretty standard organizational level assessment of patient safety. And I think that's great, and there's real merit in doing it, and I think that's worthwhile. I think it's probably going to take a little while for surveys, patient safety culture surveys, to catch up and include engagement in some shape or form in those surveys. So I think we're going to be waiting a little while for that. But in the meantime, I think organizations can do a lot in terms of looking at their local culture, you know, in departments, in teams, and getting them to reflect on the culture that they have in their team, and how they would like to improve their culture. So what I want you to do is we're going to play in a minute. Lisa's going to play a video for you. But while you're watching the video, I want you to think about the culture within your organization or within the team that you work with. I want you to be able to analyze the culture of the team where this video was played. What is it that this tells us about the culture in Eastern Health in Newfoundland, where this video is from, and try to look at this incident from beginning to end from a cultural perspective, in terms of learning, blame, leadership, and the view of the patient. And we're going to try, once the video is over, it takes about 7 minutes, to be able to have a little bit of a chat talk, in terms of where you can type into the chat for everyone to see, you know, what you think about the culture in this context, and maybe what it says about the culture in healthcare. So hopefully Lisa is able to play it just now.
Claire was born with a genetic condition known as trisomy 13. So you have 3 number 13 chromosomes. She had severe developmental delay. She did walk. She required 24-hour care. She communicated through the use of pictures. 95% of these children die before the age of 1. If they live beyond that, they're considered a long-term survivor, which Claire was. In March of 2008, my daughter, who was then 9, was diagnosed with a malformation in the back of her head, which was causing her spine to disintegrate. We needed to do surgery, and the surgery was a very planned event. It involved surgeons, neurosurgeons, and intensivists, and anesthetists, and us as Claire's parents. Claire had her surgery to correct the defect in the back of her head, which was definitely needed. If we didn't do the surgery, she would become paralyzed. Her spine would disintegrate over the course of the year. So we really had no choice. It was an urgent thing. The plan was she go to ICU, or the PICU, the Pediatric Intensive Care Unit, and she would stay there for 7 days. She would remain on a ventilator in a very deep sleep. After an apparent successful surgery, she went to ICU. We enjoyed about 12 to 24 hours of good readings on the sensors and some relief on our part. But by the time we got into day 2 in the ICU, we were in trouble. Claire initially developed pneumonia, probably from the endotracheal tube being very high in her neck and some secretions getting into her lungs that should not be there. That pneumonia was appropriately treated, but it did set her back a little bit. That in and of itself probably wouldn't have been a problem. Claire remained in the ICU for 16 days after her surgery, and at that time we consented to withdraw the ventilator that kept her alive, and she died. Initially, we thought Claire's care in the ICU was as it should be, but after the dust settled, we came to realize, or I came to realize, something didn't sit right. So I did some research and realized that Claire may not have been cared for in the manner in which I had wanted or needed her cared for. The Eastern Health was very receptive to a discussion with my husband and I. They listened, they wrote, they went away and they thought about it, and within 24 hours we were notified that there would be an external review into Claire's care. The review revealed, the review of Claire's chart and chatting with the people involved by those from Sick Kids, revealed that the ventilator management fell below the accepted standard in a pediatric intensive care unit. Her death was precipitated by an abrupt rise in carbon dioxide. And what I had found out, which led me to bring the issue to Eastern Health, and what the reviewers confirmed, was the most common cause of an increase in carbon dioxide is a blocked endotracheal tube. What do you do when you have a blocked tube? You pull it out. You replace it. The reviewers questioned as to why that was never done with Claire. The review found Claire's death to have been preventable, and that finding was accepted as such. The period of time leading into the review process and during the review was a very challenging time in the pediatric hospital within Eastern Health. Tensions ran high. They were very hurt that I had questioned their care of Claire. They were devastated when Claire died. It was one of their own. They felt that they had done everything they could. They were frustrated with me that I didn't see that side of things. As the mother, I needed the answers. My husband and I both needed the answers as Claire's parents. But as a nurse, I needed answers as well. I still worked in the same critical care division in which Claire died. I needed to feel comfortable that we had done everything we could for Claire. Once the review was launched and the review findings were back, everything fell apart. The ICU was devastated with the review findings. We were devastated with the review findings. it was the worst possible result. I stayed for a year. I gave it 1 full year after the review findings. And the frustration, the sense that I was ungrateful, it was palpable at times. So I left. There was a change in senior leadership within Eastern Health during this process. Vicki Kaminsky took over the new role, and she became the point person, the contact person within Eastern Health for questions, comments, concerns, and moving the review recommendations along. She was great support to Dave and I, my husband and I. She listened. She heard us out. She offered her thoughts. She probably heard things she didn't want to hear, but she listened to them anyway and took it all in. She met with the ICU staff. She had a forum with them. You know, tell me what the problems are. Tell me what your concerns are, was very much her approach at the time. Vicki is a nurse by background, and she did apologize for Claire's death. And it wasn't, we're sorry Claire died. It was more along the lines that Claire died because of us, not in spite of us, and for that we really are sorry. One of my apologies came from a frontline nurse who spent many an hour at Claire's bed, working very hard to keep her alive. And her apology was, if I have done something that unknowingly has contributed to Claire's death, I am really sorry. And for me, it's so important because I sat there thinking, wow, I am so privileged to have had this nurse look after Claire. This was about reviewing the case, seeing if everything was or was not done as it could and should have been, and then learning from it. It was never a bad thing. Would I do it all again with Eastern Health? Yep. I would hand Claire over to these same people.
Great. So I'm wondering if we're going to be able to do this a little bit in terms of how we can share the sort of comments. I think people could type comments, and then Lisa will be able to then sort of communicate some of that, if that sort of makes sense, and she may be able to unmute some people's lines if they want to comment. So what I would like to sort of get you to sort of comment on, well, what does that video really tell us about the culture of that team? You know, what were they, from a cultural perspective, what was the challenge that they were experiencing about learning?
So I don't have any comments coming in just yet, but hopefully people are writing in now. Just as a reminder, you can write into the question pane, or if you have a chat box, write into the chat box. I don't know, Darlene, did you have any thoughts or reflections on what we've heard?
I do. I'm going to reserve them. I'm just going to sit back for a moment and just reserve them, and hopefully people will type in their comments and questions first before I jump in.
I think we might have some sort of family representatives on the line, and I'm wondering if they have some comments. So I have something from Donna here. She says, staff found questioning the care was questioning the professional ability. And I think
yeah, so I think that, you know, culturally, you know, one of the challenges that we've really tried to, or cultural challenges that we need to move past, is that if you fail in some shape or form, or you don't do things as they could have been done, then that you are in some ways a bad person. And I think that's definitely one of the issues there, is that when something goes wrong, and if there are things that we could have done differently, that doesn't mean you're a bad person. and I think that's one of the big cultural challenges for healthcare organizations, because it's very, very hard to learn if your belief is that only bad people do bad things, right? So all of us are fallible, all of us make mistakes. The real thing in healthcare, particularly pediatric healthcare, is the consequences of those human frailties often are devastating for those who you're delivering care to. So it's trying to be able to separate out the devastating consequences of an action from what we can learn from that, and separating out the judgment part so that we're able to focus on improvement.
Donna, did you have any other comments? I could unmute your line if you'd like. Just type in yes or no if you want to be unmuted. And I have there's somebody else who's asking if it would be possible to share some questions offline through email.
Yeah.
Right, so I will get those connections made later. So I think you.
So
Donna's
Lisa,
yeah.
Lisa, it's Elaine. May I make a comment?
Certainly.
First of all, Mark, I wanted to say hi. It's been a long time, and thank you for this fantastic presentation, as always.
Nice to hear your voice, Elaine.
Same here. Mark, I think what, and I too, like Darlene, want to just reflect a little bit. This is, I've seen this video before, and it's as powerful today as it was the first time I saw it. I think the circumstances here are somewhat unique in terms of the relationship that Mom, of course, has had and has with colleagues at Eastern Health. And then for me, it just, first comment I'll put out there is it just speaks to the process of immediate reaction and human nature. So the first one is defense. The first one is, how can you accuse me of that? And then to come to that, all the mom really needed, all the family needed was that, I'm sorry. I'm sorry for the loss of this wonderful little girl. I'm sorry for what's happened. And unfortunately, if we could magically change culture, we would begin with that, as opposed to all the other reactions that happen first that include, how dare you, accuse me, or that, again, that old shame and blame has not gone away. And for me, it was just the process of reactions that hit me first, and then what Mom really needed. And if that could have been reversed, I think the outcome and the pain of this tragedy would have been easier, not gone, of course, but easier. I'm not sure if you have a comment to that, Mark.
Yeah, I mean, I think one of the things that is unique about healthcare is, so first of all, at least all the healthcare professionals I've known are very highly committed, hard-working individuals who put their life into their job, and they do their very best for their patients, and that's good. On the other hand, when something bad happens, then emotionally can be very difficult to deal with. So when harm occurs, how do we deal with that harm, and how do we manage that? So I would think that's a big issue for healthcare organizations to deal with. That the emotional toll of acknowledging to yourself that I made a mistake that anybody could have made, but it was me, and that had a consequence which was devastating for someone. That's a very big thing to ask someone to do. So I think that's a big challenge in healthcare, and I think we don't sit down enough and talk to people about the reality of how we're going to feel like. That makes sense?
Yeah, I have another comment here from Tanis. She says there are two parallel processes here. One is the quality safety review, and the second is potential disciplinary investigation. So it's hard to make staff feel safe in this quality and safety process when there's both of those things going on. So again, that sort of vulnerability.
Yeah, and I think that if we can have a bit of clarity, and James Reason's fair and just culture model is very helpful for this, to say, you know, if the event or incident or error was of a certain type and nature, then we shouldn't penalize the person, and if it was in another type, then negative consequences may follow. But I think what we need to separate it out for is the outcome. So unfortunately, when something bad happens, like an unexpected death, then we want to penalize someone, and the same error or same mistake, because it didn't happen by chance to have a negative outcome, we don't penalize people. And to a certain extent, I think that's the challenge, is that we need to be clear, not focusing on the consequences, because that's just random. The consequences may be good or bad just depending on luck or chance, and focus more on the activities in terms of what's acceptable or not acceptable. So in some organizations, they have things like golden rules. So broadly speaking, we don't use discipline following a safety incident, except if a set of about 10 golden rules have been broken. And if they've been broken, then irrespective of the outcome, then you're likely to have a disciplinary process. So I think that separating them out and being clear with people is helpful. Unfortunately, often we only look at these things when something bad happens, and that's not the time to be finding someone's not competent. We should have known the person wasn't competent a lot longer before that, and that's a failure of management rather than of just that individual. That makes sense. I'm conscious a little bit of time, and I just want to share two more things, if that's okay.
Certainly, go right ahead, Mark.
Okay, so I'm going to actually skip this part a little bit. This slide is really just to get you thinking about, well, what an ideal culture would look like, and I usually get people to say which culture they would like to work in, and I know the answer, which is everybody wants to work in a generative culture where information is actively sought, messengers are trained, and new ideas are welcomed. But it's not where any of us work, and the question is why. We create the culture, and we should therefore be clear about the culture we're trying to create. So I just want to sort of finish with a framework or model that you can use at a team level or an organization level to focus on creating the culture that you want. So this is sort of called Safety Culture Improvement System, but I think the first thing that you need to do, both at an organizational level and at a team level, is to have a vision for the culture that you want. And we talk a little bit about that in terms of, being fair and just and learning and, a whole range of different sort of attributes. But I think it's very helpful at a local and team level and at an organization level to sit down and write a short paragraph saying, in the ideal world, this is what our culture would be like, where we treat people with respect, where we investigate incidents and we're not defensive, where we learn from each other and we openly communicate and share and both give and receive feedback, where if we see something that we think is unsafe, we intervene, and when someone intervenes with us, we respond positively. Every team would probably have slightly different language around it, but I'm sure they'd probably come up with many things about where we want to be. And I think, having spent 20 years working on safety culture, the thing that both frustrates and inspires me is that, in general, there is broad agreement about the type of culture we would like to have. Everybody wants to live in a generative culture, and then the question is, well, why don't we? And I think that's a challenge that we need to address as we go forward. But I think the first step is to sit down as a group of adults and talk to each other and say, really, in the perfect world, what would it be like here? What would it look like if we had a great culture? And, be able to write that in your own words as a team and say, we could stick this up on the wall, we would agree that this is what we'd like to be. A bit sort of like a mission statement, and it may well sound a little bit motherhood and apple pie, but to a certain extent, if we put the effort in as a group of professionals to come up with how we'd like the world to be, accepting that we're not there, accepting that we are frail and we are human beings and we all have our edges and our weaknesses, but accepting that these are the people we would like to be. And interestingly, once you've written that document, out of it come a whole range of responsibilities, both for managers, supervisors, physicians, for frontline staff. Everybody has some responsibilities. If we're going to have that cultural vision, we need to know who's doing what and why, and be clear about our expectations and responsibilities. So if we have some, for example, if we learn from events, well, there's responsibilities on individuals to report the event openly and honestly. There's responsibility on specialists to provide support in investigating and understanding the causes of that event. And there may well be responsibilities on leaders and managers to take action and provide resources to resolve that issue. So everybody in this vision would have some responsibilities, and it's important we know and understand our responsibilities. We're going to need some plans and actions to help people fulfill those responsibilities. So, for example, we need to have a process to report near incidents. We maybe need to have a process to report concerns that need to be resolved, and those processes need to be working effectively, and we should be able to see how the safety systems that we have in place link back to that vision that we're trying to create. So we have a near-miss reporting system or an adverse event reporting system. Well, we have that because we're trying to learn so that we can improve. It's part of the vision that we're trying to achieve. So that's why those plans and actions exist. We're going to do some assessment, so we're going to see whether or not those plans and actions are working. We may do some assessment around our perceptions and beliefs about our culture. We're going to assess the extent to which people are living up to their expectations. So assessment is important, and it comes in on the basis of what we're doing in terms of plans and actions. And then, based on our learning from both the assessment and from audit, we review and refine our process, and we take a continuous learning approach. So, from my mind, both at an organizational level and at a local team level, this is a sort of very straightforward model that you could sit down and fill out the boxes for any sort of cultural vision that you're trying to create. You can operate at it with a small group of 20 people, you can do it, or you can do it with a large organization or entity. It becomes obviously more challenging the larger the organization becomes. But the important purpose of this model is to say to you, we need to think about the vision that we're trying to create. What is the culture we want? And then focus on locally, how do we achieve that culture? Not saying what someone else should do, but what can I do? And if we start there, then we're much more likely to be successful. So I'm going to actually skip from this actually and summarize to say really that improving patient safety culture is crucial. The culture does determine what behaviors are acceptable and unacceptable. There are a number of dimensions to culture, and we've identified those in terms of leadership and communication. Also, I think we probably need to think about how we engage families and our perspectives of families. That's important. And, we probably have to accept that cultural change is a challenging and painful process. So looking at ourselves starkly in the mirror is often a really difficult task. So that's all I have for you today. I don't think we have much time for questions, but I'm happy to answer them if that's helpful.
Wonderful. Thanks, Mark. I'm just going to pass it over to Darlene for some final thoughts and words.
Thank you so much, Mark, for that. And I guess the challenge that I was thinking about as you were walking through, I think healthcare organizations are getting better and better at, being critically reflective and analytical after an event happens. But I guess how can we apply that same critical lens to our everyday actions and our everyday care? And thinking about the video, you know, when the organization was challenged and they rose to that challenge. But how could they have backed that up to prevent it and to use some of the same critical methodologies instead of maybe making the assumption that that was the trajectory that the patient or the child was on, and therefore, you know, that was going to be the outcome before a review happened to reveal that there was something else going on. So I think that's just a challenge I'd throw out in response to building a safety culture, a proactive one as well as a reactive one for when events do happen. So I don't need a response to that, but I'll just throw that out in the interest of time. So thank you, but feel free to respond if you want to. But thank you so much, Mark, for doing that and for once again bringing us back and grounding us in patient safety culture and where we need to go. And I'll just finish up with our next call will be on February the 26th. We invite everybody on the line today to join us for the session that we'll be bringing you at that time. And as always, if you have any suggestions or comments for moving forward or presenting something for the Patient Safety Collaborative, please contact Lisa, and we're always happy to explore opportunities to bring topical sessions to you. So I'll turn it over to Mark if you have any comments for what I said, and otherwise we'll say a goodbye for today.
No, thanks, Darlene. I mean, I think you're right. Becoming more proactive is a challenge. It's got to have time and, you know, a bit of focus on what could have gone wrong. Obviously, is where organizations need to look, and culture does provide an opportunity for that at a team-based level to reflect on things not necessarily that happened or maybe happened somewhere else, and what would that look like here? What does that look like for our team? And watching a video like the one I shared today, the idea is that you do that with a team, and that gets them thinking about, well, what would that be like here, and how would we learn from our events? So that's the logic of the process.
Yeah.
Perfect. Thank you so much, and thank you to everyone on the line today, and happy Friday.
Thank you, Darlene. Thank you again, Mark. Bye-bye.
Thank you.
Bye, all.
Bye-bye. Thank you very much.